This is Stephanie Huff, and I'm recording another acid-based concept. This one is going to be on respiratory acidosis. Just an overview of respiratory acidosis. This is caused by an excessive amount of dissolved carbon dioxide or carbonic acid. It is characterized by a pH of less than 7.35, a PaCO2 of greater than 45 millimeters per mercury. Respiratory acidosis can be acute or chronic in nature. In chronic respiratory acidosis, bicarbonate is greater than 26 milliequivalents per liter. The kidneys will start to compensate by retaining bicarbonate. Looking at your pathophysiology and etiology, both your acute and chronic forms will result from carbon dioxide retention. This is caused by the alveolar hyperventilation. So they're just not getting good ventilation. Hypoxemia is frequently accompanies respiratory acidosis. It does result from a sudden failure of ventilation. And this is the exchange of oxygen and carbon dioxide. Some disorders that can lead to respiratory acidosis are going to be chest trauma, aspiration of a foreign body, acute pneumonia, overdose of sedatives or narcotics. Because respiratory acidosis occurs with sudden onset of hyperventilation, your PaCO2 level are going to rise rapidly and the pH will fall markedly. pH of 7 or lower can occur within minutes, resulting in death if it's not treated. Hypercapnia is your increased carbon dioxide levels. Also affects the neurologic function as well as cardiovascular system. Looking at chronic respiratory acidosis, this can be associated with chronic respiratory or neuromuscular conditions such as COPD, asthma, cystic fibrosis, and multiple sclerosis. These conditions affect alveolar ventilation because of airway obstruction. Could be from structural changes in the lungs, and it could be from a limited chest wall expansion. The majority have COPD with chronic bronchitis and emphysema. Your PaCO2 increases over time and remains high. The kidneys will retain bicarbonate, and you will have increase in the bicarbonate levels. The pH is often close to normal because adequate metabolic compensation. Hypercapnia, acute effects of your increase in carbon dioxide may not develop when your carbon dioxide levels rise gradually, allowing for compensatory mechanisms to occur within the body. In chronic respiratory acidosis, they're going to be at risk for what's known as carbon dioxide narcosis, and this will have manifestations of acute respiratory acidosis. Risk factors are going to include acute lung disease like pneumonia, chronic lung disease like COPD, trauma, narcotic analgesics, airway obstruction, and neuromuscular disease. Some of your manifestations. So in acute respiratory acidosis, you have PaCO2 levels that rise rapidly. This causes manifestations of hypercapnia. So they will have cerebral vasodilation. This gives them symptoms of headache, blurred vision, irritability, and mental changes. If the condition continues, loss of consciousness and their level of consciousness will progressively decrease until they actually lose consciousness. Rapid changes in their ABGs can lead to unconsciousness and ventricular fibrillation. The skin is usually warm and flush, and the pulse is usually elevated. In chronic respiratory acidosis, Manifestations can include weakness, dull headache, sleep disturbances with daytime sleepiness, impaired memory, and personality changes. Collaboration is going to require the entire healthcare team. Your respiratory therapist can help with breathing treatments. Your pharmacist and primary care provider work together in preventing giving medications that may be contraindicated in this condition. Dietitian will help with food when they need increased calories. Your diagnostic test, your ABGs are going to be done, with results having a pH less than 7.35 and a PaCO2 of greater than 45. In acute respiratory acidosis, the bicarbonate levels initially are going to be in the normal range. They will increase to greater than 28 milliequivalents per liter if the condition persists. In chronic respiratory acidosis, the PaCO2 may be significantly elevated, and bicarbonate may be significantly elevated as well. Other diagnostic tests, your serum electrolytes, chloride level will be less than 95 to 105, and that is usually in your chronic respiratory acidosis. Pulmonary function tests are done to see if chronic lung disease is the cause of the respiratory acidosis. And additional tests are used to identify the cause, such as chest x-rays and sputum studies. Pharmacologic therapy. Bronchodilators are given to open up the airway. Antibiotics are used for treatment of respiratory infections. Your narcotic antagonists, those are going to be used is if excessive narcotics or anesthesia has been the cause of acute respiratory acidosis. All right, looking at respiratory support. In either acute or chronic respiratory acidosis, it is going to focus on improving the alveolar ventilation and gas exchange. In severe acidosis and hypoxemia, intubation and mechanical ventilation may be needed. The PaCO2 levels are going to be lowered slowly to prevent complications like cardiac dysrhythmias or decreased cerebral perfusion. In chronic, oxygen is administered cautiously to prevent your carbon dioxide narcosis. Pulmonary hygiene is done. This is going to be including coughing and deep breathing exercises, breathing treatments, percussion and drainage. Adequate hydration is essential to promote removal of respiratory secretions and keep those thin. Nursing process, the primary focus is going to be on improving breathing patterns, maintaining a patent airway. You want to teach the client how to make healthy lifestyle choices. So, like if they're a smoker, you want them to stop smoking. Looking at the assessment in their health history, you want to get current manifestations such as headache, irritability, and lethargy. They may have difficulty thinking or blurred vision. You want to know how long these symptoms have been going on, any precipitating factors, which could be drug use or respiratory infection, your chronic diseases like COPD and cystic fibrosis, and then their current medications that they're on. In their physical exam, you want to make sure that you're monitoring their mental status and level of consciousness, monitoring vital signs, their skin color and temperature, the rate and depths of respirations, their pulmonary excursion, as well as lung sounds. So restoring effective alveolar ventilation and gas exchange is going to be a priority. So these are your NANDA diagnosis in order to help with this. So planning your desired outcomes can include resolution of underlying illness, that your client is going to maintain adequate fluid intake, they're going to maintain an oxygen saturation of greater than 90%, their PaCO2 level will be maintained at normal levels, and they will also be able to maintain a pH balance. Alright, so your nursing interventions are going to include frequent assessment of their respiratory status, including the rate, depth, and effort of their respirations. You also want to monitor their oxygen saturation levels and level of consciousness. A decreased respiratory rate and effort along with a decreased oxygen saturation level can signal worsening respiratory failure and respiratory acidosis. So you want to make sure that you are aware of these findings just as soon as you can, so they can be treated properly. Promoting gas exchange. You want to promptly evaluate and report ABG results. Your rapid changes in your CO2 or O2 levels may necessitate modification of the treatment plan to prevent complications of overcorrection of respiratory acidosis. You want to place them in a semi-Fowler's or Fowler's position. As tolerated, this will promote lung expansion and gas exchange. You want to administer oxygen as ordered and decrease the flow rate or the percentage as needed. You want to report any increases in somnolence, and that could indicate a suppressed respiratory drive. So if your patient's looking like they're really sleepy all the time, that may be the problem. And that is just in the response to the oxygen therapy. Promoting effective airway clearance. You want to frequently auscultate breath sounds. Any increases in your adventitious breath sounds or decreased breath sounds, such as faint or absent breath sounds, may indicate a worsening airway clearance due to obstruction or fatigue. You want to encourage pursed lip breathing. This helps to maintain open airways throughout exhalation and promotes carbon dioxide elimination. You want to frequently reposition your patient and encourage ambulation. This will promote airway clearance and lung expansion. Encouraging fluid intake helps to liquefy the secretions to promote airway clearance. Administer medications like inhaled bronchodilators to help open up those airways. And providing percussion, vibration, postural drainage as ordered to help loosen up respiratory secretions. Reducing anxiety levels. Common result of hypoxia and hypercapnia is anxiety. You want to remain with the client and monitor changes in their condition. Staying with the client is going to help decrease their anxiety and fear. Explaining procedures and treatments in short, simple sentences also reduces their fear, just because they are not scared of the unknown, because they're going to know exactly what's going on. You want to reduce environmental stimuli, use calm, reassuring manner. Always allow supportive family members to remain with the client as much as possible. Reducing their risk for injury. Clients can experience blurred vision and altered levels of consciousness, and this puts them at risk for injuries. So you want to frequently assess their level of consciousness, orientation, and their strength. Place the call alarm controls within reach. You want to manage rest and activity patterns to improve gas exchange and reduce oxygen demands on the body. Administer supplemental oxygen. This will help prevent cellular hypoxia and tissue damage. Looking at care in their community, you want to teach the client and the family about preventative measures and equipment that may be used in the home. You want to refer the client to substance abuse treatment if needed, if it's from narcotic overdoses or using illicit drugs. Encourage them to receive immunizations, especially influenza and pneumonia vaccines. Providing instructions when respiratory status is compromised. You want to involve the client and the family in alerting early symptoms that warrant immediate attention, such as headache, blurred vision or weakness, irritability, confusion, sleep disturbances, memory impairments, shortness of breath, or activity intolerance are often the earliest symptoms of worsening respiratory status. Your wheezing, grunting, and use of accessory muscles as well as cyanosis are going to be late signs, so you want to determine these when it's an early sign and not a late sign. Alright, evaluation. Some of your expected outcomes can include client maintains patent airway, they will maintain appropriate breathing patterns to meet their oxygen demands, they will remain conscious, they will not display anxiety indicating potential hypoxia, and the ABGs will reflect pH and a PaCO2 within acceptable range for the client. So this is the end of respiratory acidosis, and as always, if you have questions, please let me know and I will try to help clarify.